So ang grupo po namin, this past few weeks, ay gumagawa po ng mga, nag-organize po kami ng mga Zoom lectures for mga PHOs, CHOs, regional health colleagues, and mga health workers po sa mga hospitals, mga ganon, para po mapapacitate ang ating mga health workers and also sa mga community po nila. So, sa ngayong araw po is, ang topic po natin is Hospital Emergency Incident Command System. So, ang hospitals play a critical role in providing essential medical care during difficult times such as in disasters and public health emergencies. Many hospitals in the Philippines already outside the operate at near surge capacity. Alam naman po natin. Okay, naka-off pala yung camera. So yun po. So alam naman po natin na yung mga hospitals po natin, especially sa mga public hospitals, parang everyday maraming pasyente. So parang na near yung overcapacity na yung nangyayari. So yun ay sa normal times. Mas lalo pa po ngayong sa COVID-19, wherein expected po natin na mas lalong rarami ang ating mga pasyente. So kailangan pong merong paghahanda na gawin na institutionalize para ma-ready po tayo in terms of itong disaster po na to. So first, bibigyan ko po nandito po ngayon yung presidente po ng PSPHP, si Dr. Lester Geroy. So, ang magiging house rules lang po sa atin, mamaya po after po ng talk, pwede po tayong mag-ask ng questions and comments, pero equal na lang po tayo dito sa chat group. I-chat na lang po natin, i-type na lang po natin dito sa chat group. And later on, we will isa-isahin po natin yung ating mga questions. So, sa ngayon po, tatawagin ko po dito isang miyembro rin po sa PSPHP, wherein kung sa mga before po na nag-attend po ng ating Zoom lectures ay nag-talk rin po siya regarding incident command system naman po sa community. So, natawag po ngayon ang ating moderator, Dr. Eileen Espina.
Good afternoon, and thank you for the introduction. We are very fortunate this afternoon to have with us a very important figure in the field of disaster medicine. He is actually no stranger to us. He's a very well-known figure, and I am very honored to introduce our speaker this afternoon. Okay, he is the medical director of the Life Support Training Institute and the medical advisor of STASH.ph, and is chairman of the board of the Physicians for Peace Philippines. He was previously senior advisor for Novartis Foundation, MSD, and Globe Telecom Business Development and Strategic Development. His expertise in trauma, emergencies, and disasters started after his postgraduate training in Tel Aviv University in Israel, and he had trauma surgery fellowship in the in UPPGH and was the chair of the Department of Emergency Medicine in UPPGH. What I clearly remember about him was he was the father of the precursor of the Health Emergency Management Bureau, now of DOH. This was the Stop Death Program of DOH way back in 1994. He is also a WHO Fellow of the first diploma course in Emergency and Crisis Management and teaches the Disaster Medicine elective in the UP College of Medicine. Okay, and he also served as a consultant for the WHO in the different Pacific islands of Palau, Fiji, and Maldives. But I think he is best known as the former Undersecretary of Health and one of the descendants of our national hero, Dr. Jose Rizal, uh, colleagues, please help me welcome the current Vice President of the University of the Philippines System, no other than Dr. Ted Herbosa. Hi, Doc.
So, good afternoon, everyone. The true frontliners, I would call, kasi kayo talaga yung nasa frontline of the health system. We as emergency medicine practitioners, we are in the front lines of the hospital. But actually, you guys are in the front lines of the health system. And then let me talk about that because of my vast experience in this field. Tried to fix the connection between public health and the hospital system. And in the middle is actually emergency medicine. So the topic I chose was really about fixing the idea of how the whole system works. Some of it to give you an idea of how emergency doctors relate with the frontline people in the health system. So I'll talk about two things. It's called the HEICS, the Hospital Emergency Incident Command System. Later on became called the HEICS. And COOP, which is called, in business, it's called BCO, Business Continuity of Operations. But because we're not a business, we're a public service, it's better to call it continuity of operations planning. And this is what's often forgotten by many of the institutions. Na-mention na itong aking mga credentials and conflicts of interest. I've had a whole lifetime of disaster medicine. I was kind of pushed into it by my former boss in surgery, Dr. Alfredo Ramirez. And I ended up in Tel Aviv, where I had a lot of training in how they handle disaster medicine, disasters, and it was a country at war since the 1950s. The Stop Death program gave us a lot more experience. It was actually the Stop Death program that was recognized by WHO and earned me a fellowship in the University of Geneva. We were guinea pigs for the very first international diploma course in emergency and crisis management, and I draw a lot of my learnings from all of this. My thesis at that time was a disaster medicine elective. My only problem with the thesis was on the second semester it was offered. I started with 5 students. On the second semester, I had 15. I decided to quit offering the elective because I was the only one at that time in the Philippines. But I ended up doing what Stop Death was unable to do, improve the pre-hospital care system. We started the Bureau of Fire, EMS. We also started the Association of Chinese Volunteer Fire Brigades. And then the US aid tapped me to do studies and then eventually develop a course. This is called the Hospital Preparedness for Emergencies course in a bigger program called the PEER program, or Program for Emergency Enhancement and Response. So because of my fellowship I didn't realize that they'd also tap you to be a consultant in some of the other islands. I got to visit very beautiful islands, Fiji, Palau, Maldives. So my friends are complaining why I took those things. Of course, because we come from an island and archipelago area, our concepts and our plans fit well to island nations compared to land-based countries that actually did disaster medicine. I eventually became a board member of the World Association for Disaster and Emergency Medicine, and some training in biologicals at the Aberdeen Proving Grounds. Aberdeen Proving Grounds is the largest biological, chemical, and radionuclear facility of the United States. That's where they keep all the stuff, and we were training there for a long time. So I was able to start an emergency medicine residency. I'm glad King is here. I think my boss is also here. I saw Jimmy Galvestan actually in the list. So hello to Jimmy. And then we did a lot of things. We entered the trauma programs, the definitive surgical trauma course, advanced trauma course. And then for the locals, we developed basic emergency skills for trauma, and better basic emergency trauma treatment, etc., and emergency response. I eventually did a short stint to help emergency medicine grow at the Hospital UKM in Malaysia. That's University Kebangsaan, Malaysia. And when I came back, I was asked by Dr. Onat to help him out. Today, I also have a very important job helping out the president of the university run the whole thing. So I'm ready to retire. Anyway, this is my vast experiences. The first papal visit, John Paul II, I think, and then the SEA Games, 2 SEA Games, Payatas, poisoning in a. Annually, we handle the Nazareno there in Tacloban. You can see the damage of the storm surge, and you can see the damage of the winds, the strong winds. Yearly, we have floods, and we've learned a lot from all these experiences. We've come to take it as our ordinary. And the Philippines is really like a laboratory of disasters. When I go abroad to give talks, some of the speakers only stay 1 week or 2 weeks in a disaster place. When I start to speak, everybody keeps quiet because I'm the one that experienced the disaster. So this is my talk, and the picture specifically describes what incident command tends to actually become if you actually overdo it. So you'll have all the big top guys ordering one person to work. Actually, I saw this when I was Undersecretary of Health. When I was Undersecretary of Health, I didn't realize we were giving away 41 or 42 health programs, and we expected one municipal health officer to actually do all of this. So this is a picture of what it was like when I was at the helm at the Department of Health as a USEC. And I said, who does all of these things that we think of at the central office? It was the lowly municipal health officer and public health physicians like you who were out there doing several programs. And I think half of the year they end up doing some training of some sort. So it wasn't very effective. So this was shown to you before. This is the four major elements of the incident command system. The incident command system was actually devised in the California fires, because in the California fires, there were many responders. There was the police, the fire, the National Guard, the military. So they didn't know how to make everybody work together to fight forest fires. So they developed this multi-agency command system. So it's very good when there are multiple agencies involved. Similar to what we have today, we have an interagency task force for COVID-19. That's basically what it is when you have people from health, people from other sectors, and you want to make them work together. So I'm glad that's kicking off the ground. I've been talking to the head of operations, she's Secretary Galvez, so he will be head of operations. And I hope they put a good guy in logistics, because in my years of experience of disaster medicine, this is the most important. To me, the leadership followed by logistics and supply management is the key. It's like going to war. You cannot go to war just by sending soldiers. You need to actually find a way to feed them, to arm them, to move them out. So logistics and supply is vital. Planning is all about data, all about information, all about responding to data as it comes. And then administration and finance, of course, someone has to pay for it and someone has to do the administration. So in the hospital, it becomes more complex because the hospital is a matrix system. Whereas I'm trying to explain this because a lot of you work in the front lines with very simple clinics at primary care with probably very few staff. I don't expect you to do this incident command system, but I expect you to at least understand it so that you will know how the workings of the hospital that you actually refer to. And it would be nice, actually, my recommendation is that during the planning process, if you are working as a DTTB or as a municipal health officer or as a frontline GP or a family physician in your own clinic, it would be nice to look in to this hospital planning, because it is a health system and the health system is the one that's affected. And that's so highlighted by this particular COVID-19, because COVID-19, your admission rate is like your admission, your bed hospital occupancy days is about 3 weeks, and you spend about a week in the ICU. So that's why we have people in the ER. We call that access block, clogged up so that they can't be admitted in the ICU or in the hospital. And then it takes time before the test turns out negative. So you can't discharge them. So in this particular case, we call it access block. And one by one, 7 of the top biggest hospitals in Metro Manila gave up and said, we can't take any more COVID patients. So PGH was forced, together with 2 other hospitals, to become a COVID referral hospital. So the incident command system should be insinuated to the hospital's organizational chart. And as you can see here in this particular slide, your logistics chief is really the logistics and the people involved in logistics in your hospital. The planning chief is really somebody who's really doing all these things. And operations can be divided to the clinical services, the medical care, the ancillary services, which are the laboratory and all the radiology that also gets clogged up. And lastly is administrative or human services. So this is just another photo of just to emphasize how complex it becomes in the hospital. In a rural health unit, probably isn't going to be that complex. It's either you or me, because sometimes it's just you or the nurse or some barangay health worker helping you out. But what you need to know is to understand how you can help the system, because you're the front line. So you need to be still knowledgeable about how all of these things are, and you need to plan with your hospital that you connect. So what are the attributes of the hospital emergency incident command system? It's basically the chain or unity of command. So different specialties, different departments doing different things. They on a regular day they're on their own. But in a pandemic like COVID-19, they need to work in unity. They need to work and achieve the common goal. So they'll use common terminology. It must be flexible because it's not a plug and play. Each hospital designs their own. This job action sheets I'll talk about later are very important that everybody knows their role. And of course, documentation, all the papers, all the charts, and of course, adapting it to the specific hazard that you're handling. For standardization, it's good because you can work with police that uses ICS. You can work with the EMS that uses ICS. You can work with the public safety, the fire, and here in the National Disaster Risk Reduction Management Councils or the provincial or the regional or the barangay, they also teach ICS. So you'll be all common and using a common language that will make each other understand. And then there'll be familiarity and then all the benefits of being an efficient. Because remember what happens in disasters, your resources, your needs far outweigh the resources that you have. And the only way to improve that is to make the whole system become more efficient. So I emphasize again, the logistics chief is the most important. Really, going to a pandemic like this, look at what's happening. We are assessing our PPEs, our N95s, our ventilator capacity, and the hospitals are giving up because for PGH alone, let me explain what we've found out. We require to be a COVID hospital, 900 PPEs, N95s, face shields, booties, caps, and face masks for a day, 900 a day. So that means our stocks currently will only last us for 10 days. So that's the type of problem you have with this particular pandemic. So then we also make sure that there is food and shelter. And some of the doctors don't want to go home because they don't want to infect their family. So they'd rather stay in the hospital during the time PGH is a COVID hospital. And we've done that in some disasters so that the doctors would work. We've even made sure that their family and their wives have a place to stay in hospital grounds so that they will continue working. Otherwise, they will leave the hospital and say, I have to take care of my family and the house because it's also affected. So they're victims. So it's very important to do that. So your logistics is the go-to guy. Whatever you have, they're the ones that will fix it. Now, it's about time probably the hospital should be looking at their ventilators that are busted and try fixing it because you can't buy a new one immediately. So these are things that probably could go into planning. Again, you see this every day. There is a public information office, but there's a way to overdo this. The media wants only something. They want information. You must be able to provide that information to them. Otherwise, they will find other ways to find that information. And you'll also end up dealing with the consequences of leaked information that you're not prepared, that so-and-so director has been sick of COVID and is in home quarantine. So all these rumors will spread faster than the virus itself. So you need to be able to control the media and have a public information officer. So these are the functional responsibilities for a command. The command is in charge of overall responsibility. Sometimes it's not the director. Sometimes it's a second in command that puts up. Sometimes it's the head of ER because he's more familiar with all of this and the drills that happen. So it's really a guy who's dedicated and shows leadership in times of chaos and crisis. So you need a crisis manager. Some managers crumble in times of crisis. So importante to choose the right leader. Operations is the guy in charge of direct tactical action. Siya talaga yung nag-make sure that every patient that has to be intubated gets intubated. Every patient that needs a ventilator gets a ventilator. Every patient that needs an operation gets an operation. So ito yung tactical person mo. Yung planning, ito yung nagko-collect ng data, nag-a-analyze. They're the ones like, see, Eileen knows this. In the health system, we have speed. Speed is like the health workers that kind of submit to the central office through SMS the common symptoms. So it's a syndromic surveillance. So kami, we can see which health centers are having lots of diarrhea, which ones are having upper respiratory infection. And we send immediately, let's say, chlorine tabs or filtered water, filtered devices of water to a particular area to prevent outbreaks of diarrhea. So this is how planning and use of data analysis so that you have immediate action. And of course, logistics is the one that will tell me, I need water filtration systems. I need to send them. I need more ventilators. This guy is going to look for the ventilators that I need for the hospital. And of course, someone who will pay for everything, the finance. So what are the 6 stages in planning your hospital incident command system? Of course, there's the pre-planning. That means you sit down on a table, you do a what-if scenario, and then you go through the motions in a tabletop. The best of my recommendation is still a tabletop. I'm not very happy with this big disasters show-offs because they only end up with people who are frustrated or people who it's just like a show. I'd rather do a what if on a tabletop and think through all the needs that you will prepare for a particular hazard. So once you have an emergency like this, we are in a state of national emergency, there will be an initial response. So the initial response is that probably the alarm that yes, there is a COVID epidemic and it's in the upswing and we are now having community transmission. So this is the time you start to set up your operation center and your operations will begin. And then there will be a time that we're in this thing will slow down, the peak will happen and the curve or cases will start to go down. This is the time of stabilization and then the de-escalation and then termination and back to normal operations. So what is HEICS isn't. It's not a turnkey system. It's not a plug and play thing. It's not something that I do in my hospital at PGH and then I give it to you and it will work in your area. No, you'll have to do it on your own. It's not a policy. The policies have to be made by the hospital director and the hospital management and the health system. If it's a local health system, it's the local health, the city health officer or the municipal health office that thinks about that system. And you need to have a disaster plan because the ICS is not your disaster plan. It's a tool to use in your disaster plan. And then of course you need to replace, you need to train people, you need both of this. You need the disaster plan and the ICS for you to succeed. So what HEICS is, it's the organizational basis for emergency planning. It gives people focus and direction. It makes you realize what the big picture is, the organizational chart. You have the same role as the incident command system for public safety and the same roles in the police and the same roles in the military. So what are important are the checklists and supporting forms. I will discuss those also later and use of common terminology. So it's more about process rather than reprogram. It's a whole process that you actually do and it's a systems approach. You need to look at it from a systems perspective and you need to look at training frequency, especially in PGH. When I was head of ER and I was head of the coordinator for emergency services, half of our nurses would actually leave in a year. They would go for abroad. So that means the next person hired who did not join the last HEICS training session. So you keep training and training. Then you develop and improve it like a living document with more protocols. And then you buy more ancillary equipment, radios, computers, laptops, etc. And there are other tools that are very important. Position vest to identify who is the team leader, who is the operations chief, who is the incident commander, chart sheets, clipboards, section bins. These are where papers go through. Today we just use laptops because everything can be done electronically. But my era used all of this. I think when the electricity is down and there are no laptops, you go back to basics and you'll start using status boards, clipboards, bins, runners, also by the person that's in charge. Orange is the international color of emergency. So in any country, when it's colored orange, it's an emergency color. So ito yung important forms, no? Yung activity log, I call it a timeline. Every and you tick the box of every activity that's been done. Triage patients in the ER, checked. So that means every patient has undergone triage. Retriage the patients in red category and resuscitate patients. So all of this must be done. Today we're having COVID pandemic, and the preparations are slightly different from a mass casualty incident. I'm a trauma surgeon. I'm used to time bound, very fast. This one is a little different because we're following a reproduction curve, an R of progression. So I'm glad the government started early with the lockdown, with the enhanced community quarantine. That's actually good for us to flatten the curve. The flattening of the curve is not for the patients. The flattening of the curve is for the health system to adapt and cope. Because imagine if there is no enhanced community transmission, what will happen is the ER will be deluged with patients having pneumonia or respiratory distress. Can you imagine? Other patients will die. Patients like heart attack, stroke, a woman having delivery may have problems entering a hospital when they badly need it. And this is what we're trying to remove by doing this enhanced community quarantine. I won't go through all the forms. Very important is the job action sheet. When I was head of ER, we had a disaster box. And in the disaster box were the singlets and the IDs of the people. In the back of the ID was his job action sheet. If I passed on an ID triage officer to the ER doctor, the first thing they will read in that statement or job action, number one, do not treat any patient. So that's the number one thing he will read. Then it goes down triage. The guides for triage will be there. Triage categories, the colors, and then the nomenclature, whatever system you're using. So the job action sheet is actually a very important tool. And even in a small unit like a rural health unit or a health center, you need to do this. You need to do the job action sheets. You have to sit down, plan, write it down. If there is an outbreak of COVID type, what are the things the municipal health officer does? What are the things the rural health nurse does? What are the things the barangay health workers do? So you're a small knit unit. You must have very clear rules so that you can do more. And then you do a timeline and you identify which one should go first, which one should be done before each. So you prioritize and put a number. So and that will be also your list eventually when you evaluate your operations. So during operations, it's really the people responsible for patient care. So making sure, but in crisis mode. So you will have maybe people who are not used to working in the ER be called, like people from rehab or people from surgeons are being called to actually that. You are asked to and assist in the main goal of the planning chief is very important. He is the one that will look at the scenario. Siya yung nagpo-project. He will project, uy, mauubos na yung ating gloves by this evening. And so he needs to tell that to the commander so that you can order gloves. He is the one that looks at the stocks and the supply. You see, he is the one that looks at where to use the lifelines, water, sterilization equipment, etc. So he's the what if guy and what I can do to solve a particular situation. Sa kanya din yung mga innovation, yung mga plano as things actually come up. And they will come up. So it's very important to always have a briefing and commitment to inspire your troops and to inspire your team, especially if you have a team. This is a team approach to healthcare. You establish an implementation committee, and then you continue to train, and then whatever things you learn from an actual disaster, you use to revise your disaster plan. More recently, the HEICS has been converted to HEICS. I think HEICS developed into about 4 versions before eventually it became converted to HEICS. And this is the latest HEICS guidebook. And it shows you the history of HEICS, the principles of incident command system, the national incident management system compliance for hospital. This is American. And then the hospital emergency management program of your particular hospital, the incident command system as we were discussing it, the life cycle of the incident. So everything from alert to situation assessment and monitoring, setting up your emergency operations and implementing it, establishing the command, the hospital command center, building ICS infrastructure or its structures, and then incident action planning. So that's still a lot of planning, communication, coordination, staff and safety, staff health and safety. Here comes the looking out for PTSD, post-traumatic stress disorders, anxiety among your colleagues, especially now. We have people that made a mistake and they say it's because of being understaffed. They made a mistake in reporting a positive case that was actually negative. So that means that's a red flag signal that should have been caught, and people need to have actual rest in between this particular. The mass casualty incident is what I consider a sprint. This outbreak or pandemic is what I consider a marathon. So you reserve your energy in this particular type of situation. And then demobilization, system restoration, and then the evaluation and learning. Then this is the appendices. There are lots of things that you can learn from this particular, using all the forms that they've actually contributed. This is an example of some of the forms that you come up with. We've developed these forms in the ER when I was chief. I hope they still have it, but they can make one. For example, the incident commander. So he's given this form together with his ID and his singlet, and he starts to actually fill it up. So you can actually be able to do, it actually instructs him. If he didn't join the last disaster, all you have to do is read, and you have a checklist, and it gives you the sequence of what to do. So if you're dumb, you can just follow the instructions and just follow the checklist as it happens. Okay, so that ends my talk about the hospital continuity of continues to operate. And I think this is something that's almost forgotten by disaster plans. We don't require this for hospitals. What we require is a disaster plan and probably their incident command system. PGH has been no stranger to disaster. This is an old picture of flooding because we're at sea level. This is a picture of Yolanda. The straight line was actually the prediction of UNHCR of the this is the prediction of the UNHCR of where the storm surges would occur. The dots were all the storm surges predicted. The lower curved line was actually the actual path of Typhoon Haiyan. So it was fairly accurate. The information was there. The warnings were there, but apparently behavior, the information wasn't reflected with actual correct behavior. So Tacloban people said they were happy, they were used to disasters and typhoons. They didn't do anything. And then the people in Samar, they said, a tsunami is coming. They misinterpreted. It's not a tsunami, it's a storm surge. But it gave the correct behavior. They went all up to the hill, and there was only one mortality, someone who died of a heart attack from climbing the hill. So these are just concepts of disaster risk reduction, hazard analysis, risk management and mitigation, vulnerability assessment, and of course, DRRM. So these are very important parts of incident planning. What is important is if you don't have a disaster plan, probably you should learn about contingency planning. So these are situations wherein contingency planning becomes the important mode. One, you have no disaster plan. So for example, COVID-19, no one was prepared for a COVID because we never knew COVID. COVID is a new guy in town. We had a pandemic plan for influenza, and we had a pandemic plan for avian influenza, but these two behave differently. So basically, we don't have a disaster plan for COVID-19. So this is all contingency planning of what's happening. You may have a disaster plan, but the situation was not the one that was predicted. So you may have an earthquake plan, but what you had was a fire. Then you start contingency planning. There is a disaster plan, but those managing are not familiar with the disaster plan. This is very common because to get your hospital license, hospital directors are required to submit a plan. So someone writes the plan and it is never practiced. Nobody met the plan. It's probably in a room somewhere. It's actually in a bookshelf and nobody has even read it. Next is entry of external help who are not familiar with all the plans. Sometimes, like when Typhoon Haiyan occurred, the Department of Health took over the whole health system of the region. and both public and private were taken over for 6 months. So you send people who are from outside the town, that actually outside that area, and took care of the hospital. This is the oldest picture of a PGH ambulance that I found. I think this is sometime in 1915. Very interesting picture. So this is what I was talking about. Very important to use checklists kasi kaya kailangan now you start doing checklists. So I was involved in the safe surgery checklist also. Checklists are very important when it's a very chaotic environment. Now the job description is very important. So if you're doing contingency, start with a checklist, start with job description, and do a basis for your disaster or contingency plan. And then you review this. So we've been able to start the PGH EMS since 1997. Unfortunately, most of them were hired abroad. Maybe we trained them too good, too well. This was some of the pictures of our response in Yolanda, in Typhoon Haiyan. We didn't have any outbreak during Typhoon Haiyan. I was in charge of that, and I'm very happy to say that probably the only issue in health at that time was actually the dead bodies. But the dead bodies are not the purview of the Department of Health. It was the purview of the SOCO and the NBI, Disaster Victim Identification. So the job action sheet you can make before an actual disaster. You say epidemic, and then you say municipal health officer. What is the first thing he should do if an outbreak is called? Dengue outbreak, polio outbreak, COVID-19 pandemic. So you start to list, diba? You start to find, are there cases here? What are the tests needed? So you can start doing a list already. And then you do that as your checklist, okay? So, and then you prioritize. After you have a list, you look at which one should go first and which one should go before each other. So you can prioritize the list. Ito kailangan kong gawin muna. I need to provide a laboratory so that I can have testing before I say I'll get samples for testing. So something like that. Then you can delegate. If you now have the task, you can subdivide those tasks that you've listed down and divide them. Oh, ito bigay ko sa aking rural health nurse. I'll give this task to her because getting the sample or the specimen will be her job, but I need to provide her, etc. So it's delegation. And then the manpower. Where will you get additional manpower to help you out? This is the EMS people that we developed. I think all of them. Charlie is still here and still working with disaster and helping me out with the UP Resilience Institute. So what are the elements of continuity of operations planning? Continuity planning means implementation and management of a continuity plan. So the first one is, what are your essential functions? So if you're a hospital, a health unit, an outpatient clinic, what are the essential functions? Can you close that unit? Yeah, that's the first question. If you can close it, then baka better you just go home, or you help the hospital where they need more doctors, where you are more needed, your services might be needed. You can close the rural health center and say no clinic today because all patients have to go to the district hospital, and then you volunteer in the district hospital to add to their manpower. So what is important is what is essential in that particular situation. Ano ba ang essential in a pandemic like COVID-19? Then you must have an order of succession. This is, sino ba ang boss mo? Sino ang authority mo? Ito yung problema namin sa DTTV. Sino ba, may mga DTTV ba tayo nakikinig dyan? Kasi yung DTTV ang nagpapasweldo ay si Department of Health. Pero yung mayor, siya yung boss ng komunidad. So medyo hati, di ba? So parang we've had issues with this particular conflict, and this needs to be really dissolved. It must actually happen like the treasurer. The Bureau of Treasury, the treasurer of any LGU is actually under the DOF. So hindi sila nape-pressure. So we were thinking about doing this before. The only problem was when we started to float the idea, the other health people wanted to go back to the DOH also, to be under the Department of Health System, which cannot be because magkakagulo. So hindi natuloy yung idea namin of getting back all the municipal health officers under the Department of Health. Then delegations of authority. What can you authorize your rural health nurse to do? Some of our nurses are new, some of the nurses are experienced. So you decide what you can delegate to your nurse. Some of our nurses are almost clinical nurses in the health centers. They can take blood pressure. They even know what to prescribe already in some cases. So some more pictures to act. So the other thing is what facilities will continue? Anong facilities ang dapat isara mo or you can close down? And then, of course, your community continuity of operations, of communications. So these are some of the GIS mapping. This was done by WHO for me when I was heading Tacloban. This was a mapping of the foreign medical teams ang tawag namin nun. And now it's been changed to International Emergency Medical Teams, IMTs. But at that time, I was able to, we used for the first time in the Philippines, a WHO classification of foreign medical teams. So ginamit namin yun, and we used that for distributing the health system. What happened was the health system became better in Tacloban and Samar during the 6 months. And then it went back again to a very poor health system. Then what is important is essential records. These records are always important. I've seen many disasters where eventually, because we didn't have records, we weren't paid. Remember the ship that burned in, there was a ship that burned in Manila Bay. We took care of most of the victims of that particular case. But because my records were poor, when the insurance was about to pay, we couldn't bill because many were outpatient. And wala na, we used our own funds and resources. So it's very important because sometimes there's insurance involved in the incident and some insurance company will pay for the services rendered. So the records are very important to bill and be reimbursed. More of the maps of the different medical teams. And I would get these maps in the morning and in the afternoon, and I would know where the needs are and the allocation. So it's just like war, kung saan mo nilalagay yung mga soldiers mo, like an operations center in a war. So this this is a caricature of what it's really like in the incident command system. It says when the top level guys look down, they see only shit. When the bottom level guys look up, they only see assholes. Anyway, let's go just to break the monotony of the talk. So what are the elements of COOP? You need to do some tests, you need to do some training, you need to do some exercise, you need to devolve your control and be able to pass it on to the other people and trust your people in the team. It's all about team play. Now, what is important element of to reconstitute the organization? You reconstitute it to a way that it can survive and continue to provide services that is needed at that time. And ito yung mahirap because we're so used to day-to-day work na tapos na trabaho ko, uwi na ako, wala na akong pakialam. So in COOP, some other person will have to do some other thing to make sure that the hospital or the clinic continues to function. I cannot underemphasize the use of data. This is a caricature again that says, let's solve the problem by using big data. Although none of us have a slight idea of what to do with the data. But in this type of case, the pandemic, we need to look at the projections and the modeling of the transmission of disease to find out if we are going to stop this community quarantine or continue it for another week or so. So again, just like the incident command system, you have a readiness and preparedness, an activation phase, a full operation of execution, and then the reconstitution of your particular hospital. So when do you do COOP? The plan could be activated in response to many events: fire in a building. You don't have to close down the whole building, just the portion that actually burned. Natural disasters, you need to provide services during a natural disaster. Threat or occurrence of terrorist attacks, of course, you need to lock down the hospital to keep everybody safe. And this one, the emerging infectious diseases, which is basically what we have today, which is COVID-19, a newly emerged infectious disease of a magnitude almost as bad as the Spanish influenza. And any event that makes it possible for employees in their regular facility that could result in activation of the continuity plan. So continuity planning is simply the good practice of ensuring the execution of essential functions through all circumstances, and it is fundamental responsibility of both the public and the private as their responsibility to the stakeholders. So what many people don't realize is to create success, there are a lot of other things that actually mean. So madami ngayong social media. Ang daming social media, criticize dito, criticize doon, but they don't actually see how hard the Department of Health is working, how hard people in PGH are working to become a COVID hospital. So those are the things that you need to actually look at: persistence, failure, sacrifice, disappointment, good habits, hard work, dedication. This is what the people do not see. And it's making sure that WHO helps us, other countries help us, entry of responding countries teams. Ngayon, ang problema, it's a pandemic. No one is trying to sell us rice. No one is going to sell us other agricultural needs. So the next problem after the biosecurity is food security. Pati water, sabi nila, magkaka-shortage daw. So I don't know. So these are some of the recommendations that we learned. I will not go through this anymore. I think what's important is really social determinants. I cannot overemphasize the importance of how the public really behaves. What we need is to change behavior. Ito again, stay at home. Wala hindi pasaway pa rin eh. So we need to have better communication of how to prevent them from going. And my last slide is a comment about what we're experiencing today. Itong nakikita natin ngayon sa society natin, sometimes it takes a natural disaster to reveal a social disaster. And thank you very much, and I hope a lot of you learned from my talk. Thank you.
Thank you so
Eileen.
much, Doc Ted. Opo. Sir, dahil wala po magtatanong, ako na lang po yung magtatanong. I'm curious about if there are what can you say about the plan to have extension hospitals? Parang extension po ng hospitals to cater to mild cases. Parang,
okay, wonderful. Okay.
Parang surge capacity po.
Yes, good. I'm glad you asked that. So you mentioned the term. In an actual epidemic outbreak, the problem is really the capacity of the hospital to adapt to get more cases. So it's about the ability of the hospital to surge. Surge is defined as 10% of the hospital capacity. So what happens usually is a hospital will use its conference room, will repurpose other rooms in the hospital to become beds or ICUs. I think you saw that in Italy. So they're converting other rooms. I think in the USA they're also doing surge because they converted the whole convention center into a health facility, and they actually sent the warship, the hospital ship, USNS Comfort, was sent by Trump to. It's now there came out of Norfolk, Virginia, the other day, and it's now landed in the fort in New York. So this is very important. There are caveats to making a surge capacity. So this will talk about using a field hospital, usually a field hospital with tents. In the RITM now, they're building this designed by the architecture for the PUIs. I think they're building 4 tents outside RITM. That's the caveat. Will they be as comfortable for the patients as well? Will they increase transmission? Mga ganong issues that you have to ask. So I think it's very important that if you do a surge or a hospital, it's nicer to attach it to an existing hospital. During the dengue outbreak, measles outbreak, di ba nag-measles outbreak tayo? We set up tents outside PGH and outside San Lazaro. This was to adapt also the cases and be able to increase the capacity of the hospital. So now, dati hindi ako believe sa tent hospitals or field hospitals. But after Typhoon Haiyan, when I saw the health system decimated, my feeling was field hospitals really have a big role, and they will help develop and improve, provide care in the meantime that you're building actual hospital. Sa China, anong ginawa nila sa surge? They build 2 1,000-bed hospitals in 10 days. Yun ang kanilang surge capacity. So I actually wrote the IATF just recently, and I asked them to actually already build the PGH Diliman, which is a 700-bed facility. Sabi ko, if we can do it, we just ask the Chinese to come and build us the PGH Diliman. Actually, the PGH Diliman project is already in the build list. So it's just awaiting for all this planning and with NEDA and everything. So this is about the time to build it. I said we will just run it. So I hope they consider me not joking when I wrote Secretary Nograles asking him if they can consider this plan. Okay, so that's about surge. That's all about surge. Surge is actually a very important part. So you think through, think out of the box, think of solutions that will actually improve capacity of your hospital or health system. Sa pang suggestion ko dito sa IATF was we need hospitals that will become the hospitals or step-down facility of recovering patients. Many of the patients with COVID-19, they still can't be discharged because they haven't converted positive to negative tests. So that means the virus is still there and they're still communicable. So what I suggest is to get these patients while just awaiting to turn out negative eventually after 1 or 2 tests more to another facility so that, let's say, private hospitals like Makati Med and St. Luke's can be relieved of some of the beds. This is removing access block. You put them in another government hospital, maybe a facility that can handle all of this convalescing and better patients who just needs regular hospital care. So you remove them, discharge them early, but not from that hospital, but put them in another hospital so that that hospital can still address the new acute cases that enter. So it's a systems approach. Yes, Eileen, back to you. It's a chat box. Any other questions from our, how about my student, Cherry Grace King? She's yes.
So sir, meron pong mga tanong pa dito po. Actually,
Okay.
marami na pong pumasok na tanong.
Okay.
This is from Dr. Troy Hepte.
Okay.
Thank you for the great presentation. Can you briefly share with us how the University of the Philippines is helping us now with the COVID-19 response, and what are our main priorities in general?
Okay, now as Executive Vice President of the Philippines, we've done many things. The University of the Philippines, when the genome sequence was announced by the Chinese, I immediately called Menchit Padilla, the Chancellor of Manila. I said, they published the sequence. Aren't we going to be able to have a test for the virus? I said, Dr. Destura is doing it already. So today we have the Destura's test kit for COVID-19, which is, I heard, is going to be, the field test will be finished in April 1. That's tomorrow. It will be finished tomorrow. And if the performance was good, and I think it was good, it will be given a CPR. It's going to be the cheapest test kit right now. It is also one of the fastest in the PCR methodologies. So PCR testing, it's one of the fastest, 1 hour and a half yata lang. Whereas the others, parang 24 hours, 3 6-hour runs. Parang ganon, 3 to 4 6-hour runs. The next is PGH. We offered PGH when it seemed that the hospitals were all giving up. The director of PGH was pushed by the other private hospitals to take the lead. Of course, nagpaalam sa amin si Director Gap, pumayag kami. And when all of this was happening, we have at the UP, the University of the Philippines Resilience Institute. It's headed by a geologist, si Dr. Mahar Lagmay. But I became his co-head now because I'm a doctor and the situation is a pandemic and it's more medical. So I started guiding our scientists. Ang dami ko palang bioinformatics expert. They are now modeling. I have 3 models of the disease. One projection says it will peak by mid-April, which is good because that will go down immediately after. Another projection says May, June. The peak is May, June. So I have 3 modelers using the current data of DOH, putting it in their computations, and then putting it in graphs and pictures. For the people who want to see this, this is at endcov.ph, endcov.ph. So we now have a dashboard online, live, and we use the data of the Department of Health. We input all of those, but we're getting more data now. Provinces and cities are calling us now asking that we also do projections for their cities and localities. And we can do that if they gave us the data. So yun yung ginagawa namin. And then meron kaming telemedicine program, because one of the ways to do the treatment for the COVID patient and decrease the use of PPE is to treat them in PGH, but I'm asking them to build 4 telemedicine units. I've coordinated with Raymond Sarmiento, the head of National Telehealth. We will use the CHITS platform, the one that we use for teleproctoring, our CHITS, the revised Community Health Information Technology System. So, bali ang mangyayari doon, parang hindi kayo mag-meet ng patient for history. Magsusut ka lang pag mag-PPE ka na, at saka mag-IV, mag-blood extraction, maggagawa ng procedure. And then we're also doing videos. We have several videos online now on explaining it in Filipino. And in fact, we have a linguist that actually translated all the technical terms in Filipino. So we now have a lexicon in Filipino. So the whole of UP is actually helping it out. Last Saturday, natawagan ako ng magiging head ng operations si General Galvez, Secretary Galvez of the peace process. He's going to be head of operations. And we had a long talk, and I think they're going to use UP and all our scientists. But the public can also use our information, which is all published. We have videos, we have infographics, we have research projects that are online. Some are going to be funded by different agencies. So si Troy Hepte, sinulatan ko rin yan because he's the advisor of Senator Go. So we were hoping na matulungan din kami ni Troy. So thank you, Troy, for asking that question. That can be another lecture in itself sa dami nung ginagawa namin. Di ba, Troy? There's a lot of that stuff that they're doing, and they're all very useful for the IATF and the leaders and the DOH.
Sir, speaking of another lecture, actually there is a request here from Zweig Family Foundation on how do they cascade this lecture in the LGUs in order to help them come up with a revitalized Dream H and public health or hospital continuity plan. Maybe I can just refer this to you personally thereafter, because I can stand as your manager for this kind of engagements.
Well, you are recording. I'm seeing that this is being recorded.
Yes,
We upload this on the website of the Philippine Society of Public Health Physicians and refer to the lecture. And then I'm open to actually be a consultant. In fact, that's what I offered to Quezon City. We met with the Quezon City, and I said, with my years of experience in disaster planning. So I asked, the first question I asked when we entered the room, do you have an epidemic plan? And they didn't. They didn't have an epidemic plan. So they're at a loss. So they're doing contingency planning. I said, okay, Charlie and I can help you out with the development. So we're a government. We can just do a G to G in terms of this. So we'll be happy to advise any LGU. But it's not a cut and paste. We have to look at what you have and then how we can move forward. What are your assets? What are your resources? And then we can move on from there. But I'm willing to advise via Zoom, via email, via whatever methodology you want. We can help you out before you get inoculated by COVID-19. Right now, the ground zero of COVID-19 is NCR. We are we have the maps in the COVID.ph. You will see the maps. Medyo wala pang kulay yung mga ibang islands. So you start to prepare na, and use my lecture to call the powers that be to start preparing, kasi you just need one inoculation and then community transmission will happen. You will have an outbreak all your own in your island or in your province.
Okay po. Sir, there is a question here from Dr. King, one of your mentees.
Graduates.
Graduates pala, opo. Sa Corazon Locsin po kasi, their target is zero casualty, zero healthcare worker casualty. And her question goes this way. Should we consider legal matters as part of planning in the hospital emergency incident command system? For example, can we utilize blanket DNR plans and pre-planned limited resuscitation efforts?
I don't think
extreme po yung scenario po.
That scenario is not legal. It's not a legal question. That is a question of clinical judgment. So if you decide that that you have a limited number of ventilators, like what Italy did, they had to choose who gets the ventilator. And the choice is survivability. So you look at survivability. So the clinician will say, the chances of this guy with ARDS, 80 years old, with hypertension, congestive heart failure, and whatever diabetes, compared to a 49-year-old who has severe pneumonia, viral pneumonia, I'll put the ventilator on the 49-year-old, correct? Because the mortality is actually high as you get up older. So that's a choice we do all the time in trauma. That's also the same for a multiply injured patient in a mass casualty or a car crash. When the elderly has multiple injuries with a high injury severity score, our level of ambition to resuscitate a shock in those cases are no longer as good as a 20-year-old or a child with trauma. Kasi a child with head trauma, torso trauma, we will do everything to actually resuscitate them. So ganun din ang mangyayari dito. You will have cases all with severe pneumonia, all requiring ventilator. You will decide that is not a legal question, and I will be able to defend all of you. If you ever decide and make a protocol and you follow it and you get sued, I will be your ano what do you
Pro
call this?
bono lawyer, sir?
Ako yung
Pro
hindi
bono
lawyer,
lawyer?
hindi ako lawyer eh. Expert. Ano yung tawag doon? What do you call that?
Ano
Expert
po?
witness.
Expert witness.
I will be
Expert
your
witness.
expert witness, and you ask your lawyer. Ang tatawagin natin expert witness si Dr. Herbosa to defend your action. So that's not illegal. But yes, the answer is yes. You need legal people to actually also look at your protocols, because there are some things that you will do. You will lock down the hospital, how to handle the relatives, how to inform next of kin. And we've had cases like this. Namatay in a disaster, ang kasama, asawa, hindi pala asawa, kabit pala. And then dumadating na yung tunay na asawa. Tapos dinala na yung body. Binigay na yung body doon sa kabit. Nagagalit kayo yung totoong pamilya kasi syempre, legally, they're still married. So there are cases like that also. So you make sure that you don't get into those medical legal issues. Especially in a mass casualty incident, medical legal yan. Kung let's say active shooter or bomb blast, all the people that died have to be autopsied for medical legal purposes. Dito sa COVID, parang hindi naman medical legal eh, no? Kasi bug. Yes, okay, go ahead, Eileen. Meron pa?
Sir, kasi we are really a very disaster-prone country. Ano? God forbid. What if at the height of this COVID-19, mangyari po yung big one? Will there be a need to organize
lupit mo naman!
Hindi, sir. Alam mo naman tayo, di ba? The best disaster is no disaster. So, parang may nagtanong ko kasi dito, will there be a need to organize ng dalawang incident command system in the hospital, considering that there will be now 2 events that would need to be managed? Yun po yung essence ng tanong.
That's a good question, because the incident command system is not good for a multiple site or multiple incident command, because it confuses. The better one is the British system, yung medical major incident management support, medical and management support system, MIMS they call it. Itong ICS is good for single site, single incident, single hindi nga siya incident command system eh. It's just an incident, di ba, singular. So it fails. The incident command system fails when you start to have 2 disasters on top of each other. For that particular situation, ano na yon? Ang kasabihin ko sa inyo ganito, repeat after me. Our Father who art in heaven, hallowed be thy name.
Sige, sir. Yun
Okay.
na lang Sir, meron pong tanong dito. I think your yung information management system I think would be helpful to this question by Lester. Kasi we are getting reports of patients being parang quote-unquote lost. They don't really know where to go. Parang pinagpapasapasahan po. So the question is, with a medical direction system for COVID, like having a 911 or a single switchboard, be applicable so that we can better direct the referral system, not only for patients for admission, but also for diagnostic testing and non-COVID patients, kung saan po sila pwedeng dalhin at this time po of the pandemic.
Thank you, Eileen. Whoever asked that question was a very good question. In fact, I saw that as a problem when I saw each of the private hospitals tapping out. Di ba? Parang sa UFC, tap out ka pag suko ka na. And in a situation like this, you don't want big hospitals. They're the biggest. They're the 7 biggest hospitals in Metro Manila, and they all tapped out, 500 beds or bigger. and they all one by one tapped out and said, we cannot take any more patients in. And it's true. When you look at their ERs, there are people who are dying. I have friends who will tell me their uncle or their father was intubated in the ER for 5 days and the tests weren't result and there was no bed to be admitted. And this is the reason they are saying we're not accepting anymore. But what could have been done is a systems approach. There are 49 or 50 plus hospitals in Metro Manila. If we worked as a system together, like exactly what you described, that if you are full, I know where I can send you the nearest other hospital that can pick you up. If we work as a system and as a unit together, both the public and the private hospital, uh, magiging tataas yung capacity natin. Tataas yung capacity nating dalawa, both the public and the private sector. And then if the roles are clear, which hospital is a COVID hospital, which is a PUI hospital, which is a convalescing hospital, hindi rin tayo magkakaroon ganitong luluhod yung apat na pinaka. They're the most resource rich. These 7 hospitals have the CT scan, the MRI, and the PPEs to handle these patients. Yet sila yung lumuhod. So imagine that if, let's say, it was reversed and it was not the wealthy that were getting COVID. It was, let's say, the poor from the slums. And I'm scared because this initial cases were people who travel, they're rich, they can afford to go to a private hospital. Now we have community transmission. Pag nag-propagate yan o nag-inoculate yan ng community, whether it's in Baseco, Tondo, or in San Andres Bukid, or in Payatas in Quezon City, we're all for a hell of a trouble. So my idea is, that idea is a very good idea, and that should have been started last month. The operations for that should have been started last month. So these are the things I discussed with General Galvez, and I think he understood, being a military guy. We're in good hands. General Galvez was the same guy who led the Marawi siege. So if he won that war, I think he will lead us to win this war against COVID also. So I have a high confidence in General Galvez.
Okay,
Next.
sir. Last question na po ito. We will close at 6:30. Parang
okay.
Wala na po ako nakikitang ano. The question is, the Department of Health have guidelines on the setup of temporary facilities po for PUIs. Would you happen to have other recommendations to augment this? Or can you cite possible good examples in the Philippines where hospitals have set up this field or temporary facilities as to serve as surge facilities to cater for extensions po
for
of
PUI.
PUIs and facilities?
So the other night, I got a call from Ping De Jesus from the Clark Development Council. They're repurposing some of the hospital, some of the infrastructure of SEA Games, and converting it to a PUI hospital. So I connected them with the Department of Health. Mukhang nagka-agree sila. So they're now talking about the design, and I told them don't start it without talking to the Department of Health. So I got them connected with the USEC Lilibet David, and I think they were in unity with the plan. So I think that will start. I just have to find out how they can operate that. My idea is probably through telemedicine as well, by being an attached hospital of the Lingad, JB Lingad. Kasi kung PUI lang siya, telemedicine lang dyan, pwede na eh. You don't, and then you just have nurses that will be physically there. So that's one approach that we're taking. Now they're also doing the field hospitals pero sa grounds ng big hospital. I think they're using QI. Quezon Institute, I heard, is being repurposed by DPWH Secretary Villar to become a PUI hospital and PUM also. Kasi yung mga PUM na dapat home quarantine, isipin mo kung paano ka home quarantine, yung mga report na sinasubmit sa akin ng mga public health doctor, four families in one household. How can you do a safe self-quarantine there? Hindi talaga pwede. So the government needs to provide the facility where the people can be brought there. Even the elderly. Kasi yung Israeli model, they want to protect the elderly because the highest mortality is the elderly. Okay.
So, all in all po, nagpapasalamat po kami. Are there any other questions? Lester, baka gusto mo may sabihin? Because I would like to thank Dr. Ted Herbosa for the great lecture plus the good suggestions, and we believe that this session today, this afternoon, will go a long way in helping all of us present here and our communities in dealing with the COVID situation. Talaga pong dapat maging handa dahil sabi nga namin sa disaster medicine, the best disaster is no disaster.
Correct.
Diba, Doc?
Correct.
Opo. So, yun po ang ano. So, dapat po, i-de-link natin ang ating mga komunidad. We really need to have guidance in setting up our incident command systems, preparing our hospitals, because I think the essence of Dr. Herbosa's lecture this afternoon was that if your hospitals are well prepared, they would be able to address the following issues, no? They would be able to continue the delivery of essential services because they would have a continuity of operations plan. They would have a well-coordinated implementation of the priority actions at every level of the hospital and every area of the hospital. They would have a clear and accurate internal and external communication. So hindi po malulost yung mga tao sa ospital and also the community that they serve. I would like to acknowledge here the comments from Agusan del Sur that the hospitals and RHUs in Agusan have COVID-19 hotlines and they have set up referral protocols and it has been communicated to the community. They have also talked with the hospitals in the region and the neighboring provinces and they have beefed up their preventive measures. Congratulations, Dr. Rajaki, the PHO of Agusan del Sur, and that is really something. And also, there should be a very swift adaptation to the increasing demands. Kaya tama po yung sinabi ni Doc Ted, kailangan talaga ng daily situation reports and updates so that you can adjust your plans and response accordingly. And lastly, there should be effective use of scarce resources. Kailangan po talaga na isipin natin ito. There should be service level allocations, yung pwede na pong i-discharge sa hospital habang naghihintay na lang po ng negative result. We should have a step-down facility. Those who can be managed at home, let's manage them at home. Those that cannot be managed at home, put them in the quarantine or isolation units in the community so that our limited beds capacity in the hospitals would really be reserved for those who really, really need them. And lastly, and I'm happy that Dr. Ted mentioned this, we should be able to support our healthcare workers. There should really be a very good program of caring for the carers, especially at this point, at this time, because this pandemic is also very taxing to the mental health of our healthcare workers. Hindi po biro ang nasa frontline in times of disaster, lalong-lalo na po ngayon na ang kalaban natin ay an invisible enemy. So thank you very much, Doc Ted. It has been a pleasure being your moderator today. And
Thank
kahit
you, Eileen. Thank you,
nagdi-deja
Lester.
vu ako sa mga pictures.
Napi-PTSD ka ba?
Napi-PTSD ako.
Yolanda.
The Yolanda Queen.
Oh, okay.
Oo. So I turn this over to Lester po.
Yeah, thanks, Ma'am Eileen. Thank you, Sir Ted. And we see also a lot of friends, sa participation